everybody. Today we are going to look at psychopharmacology. For most students, this is probably one of the more challenging aspects of psychiatric nursing. If it makes you feel any better, it's pretty challenging for us as practitioners too. Most people in psychiatric care actually feel like psychopharmacology is the mainstay of treatment. Not necessarily so. In fact, truly it shouldn't be. It should be used as adjunct therapy. For individuals that have lifelong chronic mental illness, it is absolutely critical for them to be able to learn how to cope and how to be able to manage their disease process. Sometimes these medications need to be added to those areas in order to make them more effective, to be able to help them to function a little bit better, but it still shouldn't be the mainstay. It is not what's going to help an individual to regain their complete functionality and be able to live a normal daily life. So what is psychopharmacology? Psychopharmacology is the study of medications for the mind. Some of the things that we're going to learn about how these medications target symptoms. So the symptoms that an individual has if they are suffering from schizophrenia, the positive and the negative symptoms, the hearing and seeing things, the delusions that they may be experiencing. In order for us to be able to use psychopharmacology effectively, we need to know the different components to it. So really, what do we use it for? One of the things, the main thing that we use it for, of course, is to target symptoms, to make sure that when patients are suffering from those delusions, or they're suffering from hallucinations, they're suffering from depression, different mood alterations, these medications have the ability to be able to positively impact those areas. One of the things, though, that is really concerning, or that comes along with its use, is side effects and adverse reactions. Now, a side effect is something that we expect that to happen. They're unwanted, of course, but generally they don't really cause the patient any true distress, at least not for an extended period of time. They're generally what we call transient. In other words, they have them for a little while, their bodies get used to them, and then they actually go away. Adverse reactions, though, are more serious. Adverse reactions may occur because of medications that they're already taking, or it is just their body's response to the medication. But this can actually cause life-threatening events to occur. So in a lot of cases, we wind up having to stop medications because of that. The FDA also plays a big role when it comes to psychopharmacology. Any medications that we use for our patients have to be FDA approved. Now, do our patients use things that are not FDA approved? Of course they do. That's what a lot of the herbal remedies and the different things that we see that are out on the market do. But for us to be able to use them, they must be FDA approved. And FDA just simply makes sure that they're safe. And of course, that is just for the security of the drugs themselves. In order for patients to receive true benefit from medications, we're always going to be checking the effectiveness of the medications. That is going to require an ongoing assessment. In other words, they may come in and they may see us if they happen to be outpatient, and we make sure that their medications are doing what they're supposed to. If they're inpatient, we might actually do this through every shift. We check to see how their medications are working, whether or not that they're having side effects or any adverse reactions. But we always have to do that ongoing assessment to make sure that not only are the medications working, but that they are able to assist them with learning different coping mechanisms in some cases. We always want to make sure that when we are doing this assessment of their medications, that we are fully aware of what their capabilities are as far as literacy, being able to understand. Some of our patients, probably already in your clinicals you've seen, don't have really high education levels. And that requires us to be able to adjust where we're teaching them at. We certainly don't want to talk to them in a manner that we would use between college students if they have a 6th grade education, right? So making sure that they have a literacy level or that we're meeting the literacy level that they happen to be at. Always keeping in mind additionally that we take into consideration their culture. There are certain cultural considerations, particular medications may be against what their beliefs are. So it's important that we include that aspect as well. Interestingly enough, a lot of the reason that we assess these medications and their effectiveness is because less than 35% of psychiatric patients actually adhere to their medication schedule, which is not that uncommon where medications are concerned, even when it's not mental illness, is it? A lot of it is because of the side effects that they experience, and oftentimes that's simply because they haven't been educated. They don't know what to expect. Sometimes it's the dosing schedule. If instead of being allowed to take the medication once or twice a day, they might be taking it 3 or 4 times a day. In those cases, a lot of times patients will stop taking their medications, so adjustments need to be made in that way. This is why we have come out with what we call depot injections, or LAIs, long-acting injections. Part of that is for adherence, so that we know that the patient has this medication in their system for anywhere from a 4-week to even up to an 8-week or 3-month period. But for some patients, it's simply because it is what benefits them the greatest. And for our patients that may do what we call cheeking medications in order to spit them out later on, sometimes we will use what we call quick dissolving formulations as well. So you're going to hear us talk a lot about the positive and negative effects of medications. So exactly what does that mean? When I talk about the positive effects of medication, this means that when we give the medication, that the symptoms that they're having are going to resolve. So they're going to go away, alleviation of that particular problem. This means that it will improve their overall thought process, their functional capability, in general, their ability to be able to live life to the fullest degree. Negative effects are going to be sometimes the stigma that is associated with the treatment for mental illness and even for managing side effects. Some medications that we'll learn about in a few minutes require changes in an individual's diet. And again, that can really be a negative aspect of a medication. A lot of patients don't want to have to change the way that they eat. A lot of medications have what we call a discontinuation syndrome. So in other words, if they're not compliant and all of a sudden they just stop taking their medications, it may make them sick. And again, this is a negative effect of some of these medications. So we have to be prepared to do what we call taper the medicine. So we want to decrease it gradually. And we also want to make sure that our patients are fully aware of that. So there are several different classes of psychiatric medications that we're going to learn about. Specifically, you're going to learn about antipsychotic medications. You're going to learn about mood stabilizers. You're going to learn about antidepressants. You're going to learn about anxiety and sedative type medications. And you're also going to learn about stimulants. The first one that we want to spend a few minutes on is antipsychotic medication. So there's a lot to this, and I'm actually going to do another little video focusing specifically on these medications. There are actually 2 different types of antipsychotic medications that we're going to look at. We're going to look at typical, or we're going to look at conventional type of antipsychotics, which were the very first antipsychotics that came out with. This is going to be like your Haldol and your Thorazine. And then, as we found out, they only treated what we called the positive symptoms. So in other words, it treated the hallucinations, it treated the delusions, it treated the disorganized thinking. What it didn't treat, though, and which tended to be even more life-impacting, were the negative features of psychosis and schizophrenia, which included things like apathy, or alogia, which was poverty of speech, or anhedonia, or amotivational syndrome. Right? Those things which really impacted an individual's ability to be able to function on a day-to-day basis weren't affected by these medications at all. So in an effort to be able to address both the positive and the negative symptoms, antipsychotics that were newer, that truly addressed those symptoms, came out. And these were actually called atypical antipsychotics. There are a lot more of them, actually. The side effects that went along with the typicals or the conventionals were a lot more severe. We had a lot more of what we call EPSE, or extrapyramidal symptoms. And we didn't find that to be the case so much in the newer medications. What we did find to be a big problem was metabolic syndrome. So in a lot of patients, these newer medications actually cause them to have a bigger appetite, to eat more, to gain weight. It caused their blood pressures to go up. It caused their blood sugar to go up. And understandably, these had more lifelong type of problems. And with specific medications, other concerns went along with them. And again, we'll talk about those in a few minutes. Most of the antipsychotics are going to be metabolized by the liver. And the excretion, so as how our body gets rid of it, is actually going to be pretty slow. So that's why a lot of times that we can use some of these long-acting injections, is because we can give the right dose for it to actually be excreted over a 30-day period. The absorption rate actually really varies when it comes to oral administration as compared to intramuscularly, which is less variable. And the long-acting preparations, a lot of times, again, we use for patients that are non-compliant. So I don't want to spend a lot of time on which medications fall into the typical or to the conventional category and which medications fall into the atypical, because we are going to spend more time on them in a few minutes. Medications as far as typical or conventional that I want you guys to know are going to include chlorpromazine, which is Thorazine, which was the very first antipsychotic that was discovered back in the 1950s, actually. And then haloperidol or Haldol. Most of you are probably pretty familiar with that. Those are the ones that I want you to know that fall into that typical or that conventional. So what do you need to know about them? First, you need to know that they were the first ones that came out. Second, you need to know that they have lots of side effects. Third, you need to know that they are more inexpensive. We can put a patient on a typical or a conventional antipsychotic, and it probably only costs them anywhere from $4 to $10 a month. So there are definite advantages to the conventionals or the typicals. The atypicals, which we have a lot more of, that you guys are going to be responsible for learning, are going to be clozapine or Clozaril is the other name, risperidone or Risperidol, olanzapine or Zyprexa, quetiapine or Seroquel, Ziprasidone, which is Geodon. Now, they're newer, they're better tolerated, they have less side effects, but they're also very expensive. For a lot of these medications, they cost thousands of dollars a month for patients to have. And for someone that has insurance, not as big a problem. But for somebody who has no insurance, that's a big problem. It makes it very difficult for them to be able to take those medications. And as I said earlier, they have a lot more metabolic effects. Let's look at just a few of the very specific side effects that go along with antipsychotics. In general, these are some of the things that we have to consider when we're placing a patient on an antipsychotic. Some antipsychotics have cardiovascular changes, so they can have orthostatic hypotension or they can have prolonged QTc interval. A lot of them have anticholinergic effects. Some of them can cause weight gain, and actually most of them are going to cause weight gain, or that they have the propensity for that to happen. A lot of them put an individual, because of that weight gain, at risk for what? Diabetes, right? So increased blood sugar resulting in diabetes. There are unfortunately sexual side effects that are associated with a lot of antipsychotics. There are blood disorders, agranulocytosis, which can increase their risk for infection. One of the big ones that of course is not as life-threatening is neural leptic malignant syndrome, or NMS is how we refer to that, and we'll going to look at these more in a few minutes. Photosensitivity, a lot of our patients are instructed to be careful of spending a great deal of time outside. It can also lower their seizure threshold. So if we have a patient who has a history of seizures, we have to be very careful about a lot of times in giving them not just an antipsychotic, but in addition to that, we're probably going to have to increase their anti-seizure medications as well. And then of course, the medication-related movement disorders, or what we often refer to as EPSE, the extrapyramidal symptoms. Let's spend a few minutes talking about the medication-related movement disorders, or the extrapyramidal side effects, more commonly is what we call them EPSE. So there are 4 different kinds, each one of them varying in severity and what we need to do about them. There are certain medications, of course, that we give in order to counteract those particular symptoms, because truly there aren't any antipsychotics that we give that don't have at least some type of extrapyramidal or movement type symptoms that go along with them. So the first one, and probably the least severe, is called dystonia. Dystonia actually can onset within just a few days of initiating therapy, but I'll be honest and tell you that I've actually seen it happen within a few hours. And with this, actually the patient will experience muscle rigidity, and oftentimes giving them something as simple as Benadryl can actually counteract that and can stop it. The second type of EPSE that I want you guys to be familiar with is called pseudo-Parkinsonism. It can happen very abruptly. It generally actually happens within about the first 30 days of treatment. If you think about somebody that has Parkinson's, they do what we call pill rolling. We see this in patients that have that. They also develop a shuffling gait. And sometimes when they're walking, they actually kind of lean forward. So in order to prevent this, because for most of these EPSE symptoms that we see, we try to prevent them from ever happening. We may give something like Cogentin, although we really lean more towards Benadryl because it seems to work better for side effects. Another kind that we see is called akathisia. Akathisia is actually what I call continued restlessness. These individuals a lot of times will explain, or they will tell me that I just feel like I can't sit still. They constantly have to move. They may get up and they may be walking back and forth. You may find that that they'll reposition themselves multiple times, and oftentimes we actually misdiagnose this. We sometimes think that this is actually agitation on the patient's part, or we think that they're having increased psychotic symptoms, when in reality, it's just akathisia. And this is probably pretty common with a large percentage of the medications that we use. And then the last type, which is the only type, by the way, that is irreversible. All these others that we've talked about, these three others that we talked about, can be reversed. Is tardive dyskinesia. Once a patient has been on an antipsychotic for a long period of time, and I mean like 20 plus years, their chances of developing tardive dyskinesia increases significantly. Oftentimes where we really start to see some of these symptoms are in the face. We might see some circumoral puckering is what we might see. Sometimes we'll see that their tongue, when they're talking, will protrude. And when this happens, there's not a whole lot that we can do to fix it. We can give them medication in order to keep it from worsening, but once it occurs, there's not a whole lot that we can do to be able to resolve that. Which is why, again, how do we treat this? Well, we do this prophylactically. We give them medications that they take prior to this happening in an effort to keep this from happening at all. All right, so very briefly, I'm actually going to give you 3 of the medications that we use for treatment of EPSE, but you're only really going to have to know 2. The first one is called benztropine or cogentin. This is really an effective type of medication when it comes to the treatment of EPSE, but it does have some undesirable side effects. A lot of times these individuals will develop anticholinergic type of symptoms where they will have that dryness of the mouth. Trihexyphenidyl or Artane is another one that we use. These patients generally that take Artane are the ones that aren't able to tolerate cogentin real well. So it, again, is really important that we educate these patients on the side effects of these medications, what to look for, especially if they're not well tolerated. And then the one that we use probably more often than not is diphenhydramine, or better known as Benadryl. Sometimes though, when we use these particular medications to treat these EPSE, they're still ineffective. And when that happens, then we wind up having to, most likely anyway, change the medication altogether. Moving on. The next area of psychopharmacology we want to look at are the mood stabilizers or anti-mania medications is oftentimes how we refer to them. While they are used primarily to treat mania in someone who has mood instability, especially bipolar, we also use them to treat depression a lot of times, because depression is also an instability in mood, right? So the gold standard, the one that we use the most, it's our go-to when we initially start somebody, is called lithium. Lithium is a salt that occurs naturally in our body, so it is very effective in being able to manage that mood instability. The problem is that there is a very specific range, a very narrow therapeutic range is how we refer to it. You need to memorize 0.8 to 1.2. That's where lithium needs to be. Anything below that, they're not going to get enough benefit from the medication, and anything that is actually above 1.5, not necessarily 1.2, but 1.5 can actually be considered toxic. And it can be bad enough that it can actually cause them, it can cause death ultimately. So 0.8 to 1.2 is what you need to know. So lithium is the gold standard. So some of the other things that we use for anti-mania medicine are, we use anticonvulsants. We also use calcium channel blockers. We use adrenergic blocking agents, and we even use sometimes atypical antipsychotics. It just depends on what is most effective for that patient. So let's spend just a couple more minutes on lithium, being as we said that that's actually the gold standard when it comes to treating mood disorders. The indications for it, I already mentioned, are mania. Depressive episodes of bipolar is also another reason that we use it. Truly, we're not really sure exactly how it works. We know that it crosses the cell membranes, we know that it alters sodium transport, and we know that it isn't protein bound. But other than that, we're not 100% sure. The onset is about 5 to 7 days, but it may take as long as 2 weeks. So generally speaking, when we put a patient on lithium for the first time, they're probably going to be inpatient. It's excreted primarily by the kidneys, so we would want to make sure that we don't use this for a patient who has chronic kidney problems. And most of the medications that we're going to study about this semester are going to be excreted primarily through the liver, but lithium is an exception to that. So I would remember that. Some of the side effects that go along with it, a lot of people complain about being thirsty because it being what? A salt. They also complain about sometimes having a metallic taste in their mouth. Oftentimes they have to go to the bathroom more, but one of the main things that we see is that a lot of patients that take lithium develop very fine hand tremors. They can also develop drowsiness and even mild diarrhea. But the one that you're going to see most commonly is you're going to see that fine tremor, which is pretty common actually. We don't use this in women who are pregnant. Individuals who, or women who take this can actually their child can have Epstein's anomaly, which is a heart condition that is not compatible with life. And when we use these medications, or this medication, excuse me, we always want to make sure that we're doing blood work on them. We want to look at their CBC, we want to look at their thyroid, and we always want to look at their renal function as well. Other anticonvulsants that we use, but only if the patient doesn't respond to lithium. Usually these are going to be second and third choices, are valproic acid, or Depakote is another name for them. Depakote tends to work pretty well, or it has increased effectiveness, especially in patients who have issues with anger a lot of times. So besides being a great mood stabilizer, it helps specifically with individuals who have problems with that. And then lamotrigine, or Lamictal is the other name. Lamictal is also a great mood stabilizer, but Lamictal does have the side effect, which actually can be life-threatening, called Stevens-Johnson syndrome. These individuals can develop a rash all over their entire body, and this is an indicator, of course, to immediately stop the medication, and depending on severity, it, as I said earlier, can be life-threatening. So how do we know which one to use? Well, typically it just really depends on what's going on with the patient. If the patient's primary problem happens to be anger, we may choose to start some Depakote first. We find a lot of times that Lamictal is very effective, especially for women. So a lot of times we may start with Lamictal for that reason. The third area of psychopharmacology that we want to look at are the antidepressant medications. So for a lot of these medications, we may see a tiny bit of improvement within about a week. But generally speaking, it's going to take several weeks for these medications to truly reach their true effectiveness with an individual. We don't ever want to stop a patient abruptly from taking their medications, that fall into the antidepressant area. We want to do what we call taper them. So decrease their dose gradually. And this is just because they will start to develop some pretty uncomfortable symptoms if we stop them abruptly like that. One of the big things when it comes to antidepressants is that in children and in adolescents, it can actually increase the risk of suicidal behavior. That doesn't mean that we don't use it.